I'm so excited to talk to you tonight about our special guest. We have with us tonight Dr. Richard McKeon of SAMHSA, and we're here at hashtag CrisisDIR14 with the lovely @ATOS84, who many of you know, who's been our social media director, and with her assistance and with the wonderful collaboration of Dr. McKeon, we're here today to talk to you a little bit about national suicide prevention efforts and mental health system change. And so I want to introduce you properly because I'm a huge fan of yours, and I'm sure you probably get this, but for those of you who are maybe not running in suicide prevention circles exclusively or sort of newer, many of us have a little hero worship of Dr. McKeon because he has done marvelous things to progress suicide prevention in the United States. So Dr. McKeon, I'm going to read this so I don't mess this up, is the chief of the suicide prevention branch of SAMHSA, which is the Substance Abuse and Mental Health Services Administration in the U.S. Department of Health and Human Services. And in that role, Dr. McKeon oversees the policies, the practices, and the programs that are administered by the Suicide Prevention Branch in SAMHSA. And he also collaborates with national partners all across the country who are interested in reducing suicide. So we're excited that you're here. Tell us a little bit about what you spoke about this morning.
Would be happy to. It's great to be able to have a chance to talk with folks and to let you know more about some of our national suicide prevention efforts. And what I talked about this morning was really about some of the key issues moving forward regarding how systems for mental health care can be optimally financed to support crisis intervention and suicide prevention services. SAMHSA oversees various kinds of grants. So for example, we have a National Suicide Prevention Lifeline, where 165 crisis centers, at least one crisis center in every state, answers calls to the number 1-800-273-TALK or 1-800-273-8255. And if you call that number, you get the call will get delivered to the closest local crisis center to you. And so there are clinicians and trained volunteers all across the country who answer those calls, over 1 million last year alone. So it's a very important resource because sometimes, April, in the middle of the night, people may not know where they can turn if they're thinking about suicide or if they have a family member or a friend. So we want everyone to be aware of that number. That's one of the resources that are available. There's a national resource center called the Suicide Prevention Resource Center, which is probably the largest collection of suicide prevention resources on any website anywhere. It's at www.sprc.org. And there are many activities that the SPRC is engaged in. And we oversee the largest youth suicide prevention effort that's ever been undertaken in the United States. These are grants, and we just announced some awards actually earlier today to 26 states and tribes to do youth suicide prevention. And we are looking forward to doing that kind of work. Sadly, we know that suicide has been increasing in the United States. The 2012 suicide data came out recently, and now over 40,000 Americans died by suicide in that year. And among certain age groups, it's been increasing, particularly in midlife. And of the increase in suicide that took place, a very significant amount of it, actually almost 40% of the increase, took place between the ages of people between the ages of 55 and 64 alone. So wow. 4 of the grants that we announced today were to states to work in that area. And that's the first time that we've been able to have grants that are targeted to that age group. We've had for the last 10 years our youth suicide prevention programs, but by statute that can go up to the age of 24. So we're very pleased to be able to begin that work. We're here in Tennessee, April. Tennessee was one of the states that got one of those grants. And so we are looking forward to working with them. with our other youth suicide prevention grantees and all of those, such as the crisis centers around the country who are part of the National Suicide Prevention Lifeline.
And just very briefly, for those of you who've been following along on hashtag crisis DIR14, the Tennessee Suicide Prevention Network presented, and they're doing a marvelous job doing outreach and engaging the community through taking a public health approach, really. They're
Yes.
engaging survivors of suicide, attempt survivors, and also really considering the data in their state to make very targeted interventions to reduce suicide. And in the middle of these suicide rates increasing across the country, the suicide prevention community has decided to do something very ambitious. And I mean that, like, you know, some people say, well, very ambitious, and you sort of can tell that, but I mean this is something I am so proud of my field for doing. So we've decided to take the zero suicide route.
Yeah.
Can you tell people what zero suicide means?
Yes. So when we're talking about what's called the Zero Suicide Initiative, is really about making suicide prevention a core priority in healthcare services and healthcare systems. It's goal 8 and 9 of the National Strategy for Suicide Prevention that was released 2 years ago by the Surgeon General of the United States and the National Action Alliance for Suicide Prevention, which is a public-private coalition dedicated to reducing suicide in America. So goal 8 of the strategy was making suicide prevention a core priority. Now, the reason that the initiative is referred to as the Zero Suicide Initiative is that to make something a core priority, you have to be aiming to make dramatic reductions. Right? Part of this was inspired by work in the Henry Ford healthcare system.
Mm-hmm.
The Henry Ford healthcare system in Detroit first used the zero suicide approach. They were able to go 6 consecutive quarters without a death by suicide. There have been suicides since then within that system, but it has remained much lower than previously. So the idea is that if you make a substantial commitment throughout the organization to use a systemic approach to reducing suicide, that you can have success. Now, I want to emphasize why I'm saying systemic approach. Mental health systems for years, and there have always been clinicians who have worked heroically to try to save lives. But until relatively recently, whole systems have not focused on suicide prevention. And so that what we're recommending through the national strategy is that we think there are identifiable ways that systems can support clinicians in their work to reduce suicide. So these are things like making sure that there is a organized approach to identification and risk assessment. And our tools have gotten better than they had been in years past. There's now evidence around some tools that can be used. No tool can predict when an individual person might kill themselves. But there are tools that are now available that show that people who score highly on them are at greater risk for making suicide attempts over the next year. We know that it's very important that the workforce who are working to save lives have been trained in suicide risk assessment, management, and treatment, and are confident that they know what to do when somebody is thinking about suicide. So training is another important aspect that systems of care need to be attending to. We know that there are cracks in systems of care at times, particularly around continuity of care. Mm-hmm. So, for example, the time after discharge from an inpatient unit or after leaving an emergency room is a time of high risk. Our systems of care need to be designed to provide continuing contact during these high-risk times. So those are just some of the examples of the approach that's known as the Zero Suicide Initiative. But again, it's really about making suicide prevention a core priority and taking a systematic approach. And you mentioned data before. So that's an important component as well, because it's important to know if people are under our care and we lose them and they die by suicide, that we take a careful look at that. We owe it to their memory and to the people who love them to take a close look at what happened and whether there are things that we could learn from that. And if we're not looking at that, then we're not going to have chances to learn and to improve. April, as you know, suicide prevention is not an exact science.
No.
There's not a simple formula that we can say, do A, B, and C, and you will eliminate all suicides. So we need to be constantly striving, constantly learning. And we owe it to the people that we serve to take that approach. And that's really what it's trying to do.
And you had mentioned the way that you sort of had summed this up is you talk about the mental health system really revisioning itself to think about how we're providing care as a system, because it looks as if how we behave as a system may be more impactful on overall suicide rates than how one individual clinician behaves.
Yes. One of the hardest things in suicide prevention would be for an individual clinician to try to predict when another human being is going to try to kill themselves. But what we can do is try to work collaboratively with people, encourage them to tell us what they're thinking, and to work with them collaboratively to develop ways to keep them safe. And the systems of care need to be able to provide the support to clinicians in order to do that. And to also recognize where the points are where there may be greater risks. And I mentioned, care transitions or post-discharge follow-up. So in our SAMHSA grants for suicide prevention, we've made it a requirement, both for the youth grants and for the adult grants, that attention be paid to this area so that we can help to intervene during this time where we know that we're losing too many people. In the Veterans Administration, there was a massive study of veterans treated for depression, and it found that of the times when people died by suicide who had been treated by depression, the highest risk time was in the 30 days after discharge from inpatient care.
But that's a pretty big challenge because,
yes.
In VA, where I'm very lucky to work, and I don't speak on behalf of the VA, but they know that I do this and I talk a little bit about my job. What I love about doing my job is that I can watch somebody sort of as they're in the hospital and as they transition to outpatient care, I can ensure that they're reconnected with their mental health care team, that their appointments are set up, that if they lose contact, and many people who have depression, who have been suicidal, have things going on in their life. They have behaviors and ways of coping that often separate them from care at the moment that they need it the most.
Yes.
And so having somebody who watches that and who pays attention to those care transitions helps us solve those problems so that we try to the extent that we can keep someone engaged with their mental health care in those most critical periods. But it's easier to do in VA where there's one big integrated system. I mean, you're talking about a nation of systems, hundreds and thousands really of healthcare systems and individual
yes.
providers changing the way that they think about providing mental health care so that fewer people die.
That's absolutely right. And the Veterans Administration has worked hard to make suicide prevention a core priority within their systems. And so we talk with the Veterans Administration a lot about what they're learning. But because it is a national system, that there are advantages, for example, in providing continuity of care and providing follow-up when people are discharged from inpatient units, for example. And in many places, systems are far more fragmented. So it is a greater challenge. Mm-hmm. But it's a challenge that we need to do our best to meet. And those are some of the areas that we're looking at, not only to support work in this area through our grant programs, which are certainly important, but any grant program, in essence, a grant ends at some point in time. Mm-hmm. And so how to sustain these efforts over time, how to make them integral in terms of the care system, and how to finance that care over time is a vitally important effort.
And patients and individual providers can't do this for ourselves. I mean, we really do rely on our national leadership to help us figure out the best way to go about building these partnerships and creating sustained funding. Because without that, the best clinician may not be able to keep an at-risk person engaged with their care. I mean,
That's right.
This is what you mean by we're revisioning the system in order to prevent suicide, because there, in that individual moment, it looks as if we may not be able to do enough.
Well, I think that that's right. And I think that one thing I would also emphasize is that for suicide prevention to be successful, it needs an active, effective community component as well as an active, effective healthcare or clinical component. And part of the reason for that is that we know that many people do not reach out for care.
Mm-hmm.
And so a lot of our public health approaches are focused on encouraging, identifying warning signs for suicide, training people who may act as gatekeepers who can then refer the person to treatment. And so you need that community piece, and you need to maximize encouragement for people to get care. But then you also need to have the systems that can rapidly accept people into care and provide them with effective treatments and effective continuity of care if there are transitions in the levels of care that they're needing to experience.
And we talked a little bit about, our thoughts. This was wonderful. This started as some conversation that we had a couple of nights ago at the conference. It was just wonderful for me in terms of, as I developed my thinking about this issue. And we talked a little bit about what we think those barriers were for the system changing, because the mental health system has really stayed the same way for a long time, long past when a lot of our options for providing care really did change. And now people are overcoming some of these hurdles. And we talked about what we thought some of those hurdles were, like anxiety about individual clinicians or systems being blamed for a death, versus being very, very brave about looking at our data and accepting systemic responsibility for how someone might have died. And what do you think is helping people overcome this anxiety? And, like the Henry Ford system chose to not be anxious. And they chose, in fact, to look at their data, think about their system, and do something that was effective. What helps people move towards being effective here?
Well, I think that those are really important points. And SAMHSA has really tried to emphasize that prevention works and that suicide prevention is possible. Suicide is preventable. But there sometimes is both fatalism about suicide and also a real fear, as you said, of being blamed. And I don't think it's necessarily so much a fear of liability as much as it is that clinicians and people working in healthcare want to do the best. They want to keep people alive, and it is extremely painful for them as well to lose somebody to suicide, and to be blamed for that. It kind of compounds that. And of course, we know from and a very important piece of the approach that we recommend is to listen to the voices of people who have lost someone to suicide, family members. And we wouldn't have made the strides in the United States that we have in focusing on suicide prevention if it wasn't for the courage of family members who lost a loved one to suicide, who spoke up and said that this nation needs to do better. That was what led to the first national strategy for suicide prevention. That was what has led to a number of advances. And more recently, we've all become aware of the importance of listening to people who have attempted suicide, who've had experience with suicidal crises, to hear from them what would be helpful. We have to have the humility to know we don't have all the answers, and we need to listen to people who have had either personal lived experience in terms of a suicidal crisis themselves, or have lost a loved one to suicide, and to use that to try to help and to continually help evolve our systems. But a huge part of that has to do with overcoming the fear of being blamed and believing that suicide is preventable. And sometimes family members and others may have a reaction like that means that they should have been able to prevent a suicide. I think what we mean when we say that suicide is preventable is that no one's fated to die by suicide until someone takes that last terrible step. There is always hope. Up until the last moment, we know from people who have made very lethal suicide attempts and survived that many times, just moments after having taken that action, that they've had second thoughts. Many people who have been on suicide hotlines have had the experience of having a call from somebody who's just taken an overdose. Now, sometimes that could be misunderstood as that the person wasn't really serious. That's not at all the case. What the case is that it is very, very common, even typical, for there to be ambivalence about suicide. For one moment, the wish to die being stronger than the wish to live. And so it's not uncommon for someone to change their mind and then reach out for help. Depending on the method that they utilize, there may or may not be an opportunity for that help to be there. But I think that one of the things that's been most encouraging in what's referred to as the Zero Suicide Initiative is that it has helped to kind of remoralize people working in mental health systems to focus on the fact that, that there is significant change that can occur. But for that significant change to occur, it has to be adopted as a core priority. It has to be something focused on. Let me tell you just briefly the story of the Air Force Suicide Prevention Program, and it'll give you a sense of what I mean. The Air Force was very concerned about suicide back in the 1990s, and since then, of course. And so they implemented a comprehensive suicide prevention approach, including both their community and their clinical systems. They were able to reduce suicide by 1/3, so a very significant reduction. But also of interest was that accidental deaths were decreased and episodes of moderate and severe domestic violence were decreased. So there were shared risk factors that were being reached by this comprehensive, intensive suicide prevention effort. Then what happened was that the rates began to climb up. And so the Air Force took a careful look at this, and they looked at whether the program was being implemented with the same kind of fidelity as it had been initially. Mm-hmm. And they found that it wasn't. They kind of reinstituted those efforts, and they found that the rates again declined. And all of this actually was studied by researchers at the University of Rochester and published. So the message there was really important, which is that you can't have suicide be an effort for one point in time only and somehow hope that it will stick. It requires constant effort and continuing vigilance and focus. And so that's a really important piece to it. We've also found, for example, we have in our youth suicide prevention grants, we've gotten some encouraging results, finding that counties that have implemented our youth suicide prevention efforts that SAMHSA has been funding, that those counties have reduced suicide rates compared to matched counties. So that was very encouraging. However, it was only for the first year after the activity. It wasn't there for the second year. So I think that the message is the same, that it's not enough to do something once. We have to find ways to embed these practices, to embed the things that we know can have an impact continually over time so that they can continue to have a positive impact.
I mean, and what you're really saying, I think of an analogy like washing our hands. So in the medical community for a long time, the importance of germ theory and washing your hands wasn't something that they understood.
Right.
And far in advance of this becoming common practice in the medical community to wash your hands frequently before you interact with patients, there was this sort of transition into really understanding and adopting this. And it took a lot of time for the medical community, yes, for everyone to begin that practice. And then once people began washing their hands and practicing different hygiene practices, right, patients didn't get sick as often, they had better medical outcomes. But what we know, in fact, is if in a medical community or health organization, doctors, if left to their own devices, and this is just common, this isn't about individual doctors, will only wash their hands about 1/3 of the time without some sort of reminder intervention. But when interventions are constantly in place, which it takes sort of constant vigilance, then then doctors and their staff will do those proper practices and nobody gets sick. But you have to have systemically a way to remind the doctors, right? And it has a massive impact on outcomes. When we think about suicide prevention, there are systemically things that we know save lives.
Mhm.
Like, we're not talking like we think this is a matter of style or it's just something we personally value. It is, we could probably make suicide no longer be the 10th leading cause of death. Reasonably, we could do this today if there was will, but what you're saying is it would take constant vigilance, and we would have to change the way we practiced every day, and we would have to put something in place that didn't disappear.
That's exactly right. And I think the analogy with hand washing is great. And I used to work in a hospital-based community mental health system, and I remember like going into the restroom and seeing these signs about washing your hands and saying, "Oh, really? 30 seconds? That's a long time." And it took time for that to be incorporated. The interesting analogy with that is that it was common in hospitals, as I understand it, to regard hospital-acquired infections as being something you really couldn't do anything about.
Mm-hmm.
And they found that that was not the case, that you can reduce it. The Institute of Medicine a number of years ago wrote a report that said, "To err is human." So the idea being that you can't count on human perfection. You can't count on somehow an individual clinician always doing a perfect suicide risk assessment. And we're always going to be dependent to some degree on the willingness of the person to tell us what's going on in their heart and mind. So the systems have to be designed to provide that care, not just depending on individual clinicians to always end up at the same place. And so that's an important lesson in healthcare in general, and it has a lot of applicability to suicide prevention. Now, as you know, the Department of Defense and the Veterans Administration have developed clinical practice guidelines with a lot of specificity to them for working with suicidal patients. So there are a lot of things that we know that are evidence-based, or at least are best practices that can be applied, but the systems have to be in place for them to be actually utilized, for people to be trained in them. It has to be given systematic and systemic attention.
So you're inspiring some people. So we do have some folks who are monitoring our social media channels right now, and I understand that you've gotten a question. And if I could have Dr. Bart Andrews, if you could come bring that question around maybe and let us know. We've got some folks who are assisting us today. We're really, really grateful. At ATOS 84 has several people on a social media team, and we have at Dr. Bart Andrews. And the question is, I'm not finding it. I'm so sorry.
Right there.
Whoop. To talk a little bit more about primary care and suicide prevention efforts that SAMHSA is working on.
Well, that's a great question. We know that primary care is extremely important in suicide prevention because when we look at those who have died by suicide, there are a significant number of them who have never touched the mental health system and have never received any kind of behavioral health care. But very large numbers of them have touched the primary care system in one way or another. There was a study that came out just within the last year from a major health plan. Greg Simon was the lead researcher on this. And one of the things that they found was that a very significant number of the people who died by suicide never received within the healthcare system a behavioral health diagnosis. Now we know most of the psychological autopsy studies suggest that as many as 90% of those who died by suicide have a diagnosable mental or substance abuse disorder. Yet many times that may not be diagnosed within primary care. So SAMHSA is doing a number of different things. SAMHSA has grant programs to support what is called integrated care. And so this involves both behavioral health services being available within primary care, but also primary care services being available for those who are receiving behavioral health care. Because we know that the lifespan for those with behavioral health conditions, not only because of suicide, is less. And that's because of a range of behavioral health conditions. So SAMHSA is working hard in that. There are also some specific suicide prevention tools that we have. For example, the Suicide Prevention Resource Center has created a toolkit for rural primary care suicide prevention that contains a number of tools that can be used. A lot of it can be used in non-rural areas as well. In January, we'll be coming out with an app that will be designed for both behavioral health, but also primary care providers to be able to utilize. It will include...
Hold on. SAMHSA is releasing an app in January?
In January, yes.
How can I get someone to come on SPSM and tell everybody about it?
I can arrange that for you.
I would love that. We have a primary care following, and so I want to give a shout out to @Dr. Mike Sevilla, and if one of our team can maybe even tweet him. We know the primary care social media folks, and we would love to invite them to hear more about that if that's something we can arrange.
Absolutely, I'm sure we can arrange that.
But anyway, you were talking about you're releasing the app, and I got excited.
Well, we're looking forward to it. That it will be a tool. It will connect to a number of different resources. It will have an interactive guide to help people do a suicide risk assessment. And it's using a tool that was developed originally by Dr. Doug Jacobs, who headed for the American Psychiatric Association, their committee that developed guidelines on managing suicide risk. And we've had this card called the safety card available free and in bulk through SAMHSA's store. So people can get hard copies, and of course they can download there. But this will make it available as an interactive app that can be used to help walk people through doing a suicide risk assessment. Because we know that clinicians, providers become very worried about doing the wrong thing. And so we want there to be tools there for them. And the Suicide Prevention Resource Center is a variety of tools for clinicians, but this app includes primary care specifically as one of the targeted audiences for the app.
So, I mean, when you're talking about system change, you're saying that this app can, like, for example, a primary care doctor is going to have a very limited amount of time and training in mental health, could walk through something that would help remind them of all of the steps that they really need to be doing when they're doing a suicide risk assessment, to help them get a sense of what's happening with the patient in front of them, and maybe even open the doorway for safety planning and a referral. Because we wouldn't want them to leave their primary care doctor's office without a safety plan. But that because I work with primary care doctors all the time, and talk them through how to do a safety plan, because they worry. Once I explain it has 6 steps in it, and there's a formula, and those wonderful patient skills that you have where you talk to your patient, you're gonna walk through this sort of process, and it will be fine. But initially the suicide word becomes so scary, it's almost like they can't think that it can be broken down into something that they can do. But it's a skill that you can follow a structure and do well.
That's right. We of course want everyone, when they're working around issues of suicide, of course, to take it very seriously, to have appropriate concern. But if people are so anxious that they don't know what to do, that would be a problem. Yeah. You would be really worried if you had a family member going into surgery, and the surgeon started to talk about how anxious they were about performing.
Correct.
You want the clinical workforce to feel confident that they know what they're doing. So that is, and to do that, they need appropriate tools. And the primary care example is a great one, because it needs to be broken down into who has what role. As most primary care offices have a number of people working there. They have different roles. And so if it's specific, people know ahead of time what their part is, what they need to do, things are going to work out smoother than if there's no protocol, if there's no defined approach, but suddenly somebody is suicidal and people don't know exactly what to do.
Yeah, that's when things are missed. And so if it's a part of the system, because we know that I want to say it's about 50% of people see their primary care doctor within a month of their suicide.
Yes.
And even 25% of them is within 24 hours.
Yes.
And so it would be very logical that we would want to very much support a primary care setting system to feel comfortable in knowing what to do to immediately address assessment and safety, and then really smoothly accomplish a referral to a mental health professional.
Absolutely. Yeah, a great example of that, I mentioned SAMHSA's youth suicide prevention program called the Garrett Lee Smith program, where it's named after the son of a United States senator who tragically died by suicide. And that was Garrett Lee Smith, and his father, former United States Senator Gordon Smith, became a powerful champion and advocate for suicide prevention in the United States Congress. The act was passed, signed into law by President Bush. So it supported a wide variety of youth suicide prevention efforts, but an example that's very relevant to what we're talking about now is that in the state of Pennsylvania, their primary focus has been on suicide prevention within pediatric care. And they have been doing a lot of behavioral health screening, and it's automated. So basically, as you know, you go to the doctor's office and you're asked to fill out forms, etc. So there's an automated screening that looks at a number of different things: mood disorder, substance abuse, anxiety, trauma, as well as asking about suicide. And then that information is then available for the pediatrician or family physician before the encounter. So again, it's to finding out, well, what's the role of how do you find this out? You don't want to put everything on the shoulders of the primary
Correct.
care physician, because you have to be mindful of the fact that they have limited time to make an intervention. So you want something that's going to be feasible and that's built into the practice.
The next follow-up question is, what about primary care or crisis care follow-up based on the emergency department follow-up model? Like, and some of our viewers might not know what the emergency department follow-up model is. Maybe you could say sort of what that is and how we would then involve primary care in follow-ups for emergency room visits after a suicide attempt.
Yeah, so the challenge with emergency department visits is that we know when you look at the data now that actually slightly more than half of people who go to emergency rooms having made a suicide attempt, that more than half are not admitted to the hospital as inpatients. And so many people are discharged. But the issue is the same when somebody leaves an inpatient unit and when they leave an emergency department, is that we can't assume that they're no longer at risk the moment they step outside that door. And it's even more complicated in emergency departments, because on an inpatient unit, there can be time to set up a discharge plan, to make contact with the provider that will follow up afterwards. In an emergency department, that time is often not there. Things have to be done much more quickly. And so what we found is that it's a time of high risk, but it's also a time when intervention can be effective. And there are some places where in some smaller systems or some rural counties sometimes, where the system isn't as complex, that they may be able to kind of keep track of everyone if it's all part of the same system. But many times what happens in many places is that someone may be given the phone number for a mental health agency to call.
And that's all the discharge that they get,
And
which is you person with depression who feels really bad, we want you to go take care of this.
Right. And then if that person then has to call the mental health agency, they would, that agency would typically not have any information about the fact that this was somebody who was at risk and made a suicide attempt, unless the person themselves, tells them. And there could be a waiting list at the mental health facility. So yes. There are lots of things that can go wrong during that period of time. So, and it's also quite true, April, in healthcare in general, that these issues of care transitions are very important for many disorders. So what becomes important is to have a way to do that kind of follow-up. One way that we have looked at is using the crisis centers who are part of the National Suicide Prevention Lifeline. We've given small grants to crisis centers to do this kind of follow-up and to have agreements with emergency departments so that the person would be asked, would they be willing to be followed up? Mm-hmm. One of the things that our evaluation studies have found is that when you talk to people who, if you ask them if they're okay with being followed up on, and then you stay in contact with them, that they feel that those kinds of follow-up contacts, which a lot of times aren't face-to-face, a lot of times they're phone calls, that they feel are very important.
Mm-hmm.
And people indicate in our evaluation studies that they play an important role in keeping them safe and not making another suicide attempt. And of course, during that time, we like to work with them around safety plans and work on trying to link them to ongoing treatment. One of the things that we found in one of our earlier studies that SAMHSA supported was that people who were calling the suicide hotlines were experiencing a reduction in hopelessness and suicidal ideation around the time of the call.
Mm-hmm.
But there was a significant subgroup who, in the weeks afterwards, would start to think about suicide again. But only a small number of them had connected to mental health care. And so the notion that folks needed to be followed up for that, to be offered additional help, we began to feel was extremely important. And the work that we've done since then suggests that people value getting that kind of care. One thing that stuck with me is one person who was part of the follow-up study put it this way, said that, when I was in crisis and I called, I felt stupid for calling. When I was called by the crisis center, I felt cared about.
Exactly. And, I think that's one of the things that I think we're finding out more and more in mental health is that sense that somebody has thought about you without you coming and asking for them to attend to your pain does something for you. It creates a sense of compassion and healing that's in fact really safety providing. We're also getting some questions about if we're doing emergency room follow-ups, are we involving family members? And I think also we could talk about involving family members in safety planning.
Well, I think it's very important to involve family members in safety planning. And it is often the case, and I used to work as the director of a psychiatric emergency service. And so many times, not all of the time, but many times, family members were present, and we would be trying to get additional information from them. And if they weren't present, we would try to reach out to them. But I think that there is a tendency at times to not incorporate the family. And so that's really an important component, I think, of a comprehensive approach focusing on suicide prevention. And while it is true that there may be times that a person may refuse contact with their family, what I found was that if you explained why it was important, the great majority of people would agree.
Yes.
And so I think it's important that it be kind of a routine part of our practice to try to engage the family, try to make sure that the person at risk is aware that this can be a help and support to them. And for us to be willing to take the time, even in the emergency room, whether on the emergency room or in an outpatient clinic or in an inpatient unit, to make sure that we take the time to engage family members, to talk to them about what would be most helpful, to educate them about both the underlying behavioral health conditions, if a person has a mood disorder, for example, as well as what would be most helpful, for everyone concerned moving forward. Sometimes family members will feel like they're always going to be worried that there'll be another suicide attempt, and may be always asking about it.
Mm-hmm.
And the person may start to get really tense that the family member is always asking them about
Mm-hmm.
it. But if you take the time to have a conversation to say, of course a family member is going to be worried. What do you think will be the most helpful? And so that there's a collaborative plan between the provider and the person who is having a crisis involving suicide, and their family members or other loved ones, I think is the ideal. And it's what we should strive for.
So we're going to be wrapping up, and I want to talk about, we've hit a bunch of levels as we've talked about this. And so as we're sort of thinking about our final thoughts, you've talked about the mental health system really revisioning itself. And we've talked everywhere from on very big policies about what research is funded by grants, and how we have a crisis line nationally that creates a net of safety and resource for our country, all the way down to individuals getting connected with their family, with their individual doctors after suicide attempts or suicidal thoughts and feelings. what are your thoughts about if you're going to have a real change, a mental health system change? How do you get buy-in from this very, very large national policy level all the way down to buy-in in individuals and communities?
Well, I think that that's where it becomes important to be willing to have conversations about suicide. If we avoid the topic, then those changes can never happen. And, it's an issue on so many levels. If somebody's thinking about suicide and no one's willing to ask them the question, even if they appear depressed or whatever, then that person is left isolated with that. If they're asked about it, at least it opens up an opportunity for them to talk. But it's not only in those clinical circumstances where there may be anxiety in talking about suicide. Most people many people have expressed the idea that if you ask someone about suicide, you're going to put the idea in their head. That's been researched, and we know that's false. So having conversations about suicide, they're important on the individual clinical level, and they're important on the organizational level and on the policy levels, to be willing to look at it. Be willing, if you're a healthcare system, to be willing to look at how many people in our system died by suicide,
mm-hmm.
and what can we learn from that.
Mm-hmm.
And so it's essential that those conversations be able to take place on many different levels. And that's part of making suicide prevention a priority. If we're not willing to talk about it, then we're not going to be able to make changes to reduce suicide. And it is very clear that as a nation, we have a responsibility to give our best efforts.
I mean, you're just saying that on all these levels, we have to become willing. We have to become willing to say that suicide is happening, and we have to be willing to say there are things that we could change. And if we're willing to face that, we could probably save some lives. I mean, that's really
Yes.
at the core of all these, at all these levels. It's just a willingness to say that this is happening, and a change could save lives if we're willing to do it.
Yes.
I really thank you for the opportunity to talk about suicide prevention on all of these levels. I'm grateful for our participation out in the social media verse. We're going to be chatting about this conference, #CrisisDIR14, if you follow it over the next couple of days. Additionally, this Sunday night, 9 p.m. Central, #SPSM will happen like it does every week. We're going to talk about social media efforts, for example, like having Dr. McKeon on with us to live vlog with us tonight. Like, how cool is that? We're going to talk about how we arrange some of these things and how we're becoming more sophisticated as a community and using social media messaging to advance this conversation at all those levels. Thank you for being with us tonight.
You're very welcome.